In this presentation, we will approach cardiac arrhythmias using a structured clinical pharmacist framework that integrates electrophysiology, ECG interpretation, pharmacotherapy, and emergency management. Arrhythmias occur when the heart's normal electrical activity becomes abnormal, leading to rhythms that are too fast, too slow, or disorganized. These abnormalities occur because of dysfunction in impulse generation, impulse conduction, or both. Clinically, arrhythmias matter because they can reduce cardiac output, worsen heart failure, increase thromboembolic risk, trigger hemodynamic instability, or lead to sudden cardiac death. Our goal is to build an algorithmic understanding that connects ECG findings with the underlying mechanism and appropriate treatment strategy. This slide explains how normal cardiac electrical conduction occurs. Electrical impulses normally begin in the sinoatrial, or SA node, which serves as the primary pacemaker because it has the fastest intrinsic firing rate. The impulse then travels through the atria to the atrioventricular, or AV node, where conduction slows physiologically before continuing through the His-Purkinje system into the ventricles. This sequence occurs because the heart requires coordinated atrial contraction followed by ventricular contraction to maintain effective cardiac output. Clinically, this matters because the location where a rhythm originates strongly influences heart rate, QRS width, symptoms, and treatment decisions. Rhythms arising lower in the conduction system are typically slower and produce wider QRS complexes. Different regions of the conduction system have different intrinsic pacemaker rates. The SA node normally fires at 60 to 100 beats per minute, the AV node at approximately 40 to 60 beats per minute, and ventricular or Purkinje tissue at about 20 to 40 beats per minute. This occurs because automaticity progressively decreases as conduction tissue moves farther away from the SA node. Clinically, this matters because when higher pacemakers fail, lower escape pacemakers take over, producing slower rhythms that may compromise perfusion. The origin of the rhythm also affects QRS morphology, since ventricular escape rhythms generally create wide QRS complexes. This slide compares slow response cells and fast response cells. Slow response cells, located mainly in the SA and AV nodes, depend primarily on calcium influx during phase 0 depolarization. Fast response cells, including atrial tissue, ventricular myocardium, and the His-Purkinje system, depend primarily on sodium influx for rapid depolarization. These differences exist because nodal tissue is specialized for automaticity and conduction delay, while ventricular tissue is specialized for rapid impulse propagation. Clinically, this distinction is essential because antiarrhythmic drugs target specific ion channels. Calcium channel blockers and beta blockers primarily affect nodal tissue, whereas sodium channel blockers mainly affect ventricular conduction and QRS duration. Ions movement within SA and AV nodal cells. During phase 4, funny sodium currents and T-type calcium channels create spontaneous depolarization that determines heart rate. During phase 0, calcium influx through L-type calcium channels causes depolarization and AV nodal conduction. During phase 3, potassium efflux repolarizes the cell. These mechanisms occur because nodal tissue lacks fast sodium channels and relies on calcium-dependent conduction. Clinically, this matters because AV nodal arrhythmias respond best to therapies that affect calcium channels, beta receptors, or adenosine receptors. Understanding these ion channels helps predict ECG effects such as PR interval prolongation. Ventricular myocytes and the His-Purkinje system are fast-response cardiac cells. Rapid sodium influx during phase 0 creates fast depolarization and determines conduction velocity and QRS duration. Potassium channels govern repolarization and influence the QT interval, while calcium influx during the plateau phase supports contraction. These mechanisms exist because ventricular tissue must rapidly conduct impulses and generate coordinated contraction. Clinically, this matters because sodium channel blockade widens the QRS complex, while potassium channel blockade prolongs the QT interval and increases the risk of torsades de pointes. This slide links ECG intervals to ion channel activity. The PR interval reflects AV nodal conduction and therefore depends largely on calcium channels. The QRS duration reflects ventricular depolarization and depends mainly on sodium channels. The QD interval reflects ventricular repolarization and is strongly influenced by potassium channels. These relationships occur because ECG intervals are surface manifestations of cellular electrophysiology. Clinically, this matters because specific ECG changes help identify which ion channels are being affected by disease states or medications, allowing clinicians to anticipate toxicity and select targeted therapy. There are three major mechanisms responsible for arrhythmias: enhanced automaticity, triggered activity, and re-entry. Enhanced automaticity occurs when abnormal pacemaker cells fire faster than the SA node. Triggered activity occurs because after depolarizations develop during or after repolarization, often due to calcium overload or prolonged QD intervals. Re-entry occurs when an electrical impulse repeatedly circulates through a conduction loop because of differing conduction speeds and unidirectional block. Clinically, this matters because most tachyarrhythmias encountered in practice are reentrant arrhythmias, and therapies such as adenosine, cardioversion, or catheter ablation are specifically designed to interrupt re-entry circuits. Bradyarrhythmias occur when impulse formation or conduction is impaired, while tachyarrhythmias occur because of abnormal impulse generation or re-entry circuits. These disturbances develop because of conduction system disease, autonomic imbalance, ischemia, fibrosis, electrolyte abnormalities, or medication effects. This distinction matters because slow rhythms are usually managed by restoring conduction or pacing, whereas fast rhythms are managed by slowing conduction, terminating re-entry, or suppressing abnormal automaticity. This slide introduces a structured approach to ECG interpretation. The clinician first determines whether the patient is hemodynamically stable, then evaluates heart rate, QRS width, rhythm regularity, and P waves. This organized method exists because arrhythmia interpretation becomes safer and more accurate when approached systematically rather than by pattern recognition alone. Clinically, this matters because missing instability or misclassifying a rhythm can delay life-saving interventions such as cardioversion or defibrillation. Differentiate narrow complex and wide complex tachycardias. Narrow complexes indicate ventricular activation through the normal His-Purkinje system, suggesting a supraventricular origin. Wide complexes indicate ventricular origin or abnormal ventricular conduction. This distinction exists because ventricular depolarization becomes slower and less coordinated when impulses bypass the normal conduction system. This matters clinically because wide complex tachycardia must be treated as ventricular tachycardia until proven otherwise, since incorrect therapy can precipitate cardiovascular collapse. Rhythm regularity. Regular rhythms are commonly caused by organized re-entry circuits, while irregular rhythms usually reflect chaotic atrial activity or varying ventricular conduction. These patterns occur because some arrhythmias maintain stable conduction pathways while others generate continuously changing impulse propagation. Clinically, irregular rhythms strongly suggest atrial fibrillation, while regular narrow tachycardias often indicate AV nodal re-entry tachycardia. Assessing the hemodynamic stability is very important before selecting therapy. Instability may present as hypotension, chest pain, shock, pulmonary edema, or altered mental status. These symptoms occur because severe arrhythmias can drastically reduce cardiac output and impair organ perfusion. This matters because unstable arrhythmias require immediate electrical therapy rather than delayed pharmacologic management. This patient has a narrow, regular tachycardia without visible P waves, which strongly suggests AV nodal reentrant tachycardia. The rhythm occurs because a reentry circuit forms within the AV node using fast and slow conduction pathways. AV-NRT is highly responsive to therapies that transiently block AV nodal conduction, especially adenosine. This case demonstrates a narrow complex, irregular tachycardia without organized P waves, consistent with atrial fibrillation. AF occurs because multiple chaotic atrial impulses continuously bombard the AV node, eliminating coordinated atrial contraction. Atrial fibrillation increases stroke risk, may reduce cardiac output, and often requires rate control and anticoagulation assessment. This patient presents with hypotension and a wide, regular tachycardia, making ventricular tachycardia the most likely diagnosis. Ventricular tachycardia usually develops because scar tissue from a prior myocardial infarction creates a re-entry circuit within the ventricular myocardium. Since ventricular activation occurs outside the normal His-Purkinje system, the QRS complex becomes wide. Clinically, VT can rapidly deteriorate into ventricular fibrillation and sudden cardiac death. In unstable patients, immediate synchronized cardioversion is life-saving and should not be delayed for medication trials. This case demonstrates a wide, irregular tachycardia, which is especially dangerous because it may represent polymorphic ventricular tachycardia or atrial fibrillation with pre-excitation, such as Wolff-Parkinson-White syndrome. The rhythm becomes irregular because multiple conduction pathways or unstable ventricular activation patterns are present. AV nodal blocking agents like beta blockers, calcium channel blockers, digoxin, and adenosine can worsen conduction through accessory pathways and precipitate ventricular fibrillation. This summary slide reinforces the core ECG recognition patterns. Narrow regular tachycardia typically suggests AV-NRT or another supraventricular tachycardia. Narrow irregular rhythms strongly suggest atrial fibrillation. Wide regular rhythms should be considered ventricular tachycardia until proven otherwise, while wide irregular rhythms raise concern for polymorphic VT or pre-excited atrial fibrillation. These patterns occur because ECG morphology reflects the origin and conduction pathway of the arrhythmia. Clinically, rapid pattern recognition improves emergency decision-making and guides immediate treatment. Bradyarrhythmias are cardiac rhythms with heart rates below 60 beats per minute caused by impaired impulse formation or impaired impulse conduction. These abnormalities develop because of SA node dysfunction, AV nodal disease, ischemia, fibrosis, medication effects, or electrolyte disturbances. Severe bradycardia can reduce cerebral and coronary perfusion, leading to fatigue, dizziness, syncope, hypotension, or shock. Sinus node dysfunction occurs when the SA node cannot generate impulses appropriately or consistently. This may produce sinus bradycardia, sinus pauses, sinus arrest, or alternating tachycardia and bradycardia. These problems usually develop because of age-related fibrosis, ischemia, or medications that suppress nodal activity. Symptomatic patients often require permanent pacemaker implantation to maintain an adequate heart rate and perfusion. AV blocks occur when atrial impulses are delayed or blocked before reaching the ventricles. These conduction abnormalities may occur at the AV node or within the His-Purkinje system because of ischemia, fibrosis, medications, or degenerative conduction disease. AV blocks matter because progression to complete heart block can cause profound bradycardia, syncope, or sudden cardiac death. A prolonged PR interval with preserved conduction of every atrial impulse characterizes first-degree AV block. This occurs because AV nodal conduction slows, commonly due to increased vagal tone or AV nodal blocking medications. This usually has minimal significance but may indicate underlying conduction system disease or excessive medication effect. Second-degree AV block involves intermittent failure of atrial impulses to conduct to the ventricles. Mobitz 1 occurs because of progressive AV nodal fatigue, while Mobitz 2 reflects disease below the AV node within the His-Purkinje system. This distinction matters because Mobitz 2 has a high risk of progressing to complete heart block and often requires permanent pacemaker placement. Third-degree AV block occurs when no atrial impulses conduct to the ventricles, causing complete AV dissociation. The atria and ventricles beat independently because the ventricles rely on escape pacemakers for activation. Clinically, ventricular escape rhythms are usually too slow to maintain adequate perfusion, making pacing urgently necessary. The outlines treatment of symptomatic bradycardia. Atropine is administered first because it reduces vagal influence on the heart and increases heart rate. If atropine fails, pacing or vasoactive infusions are used to support cardiac output and perfusion. Early recognition and treatment of unstable bradycardia prevent progression to shock or cardiac arrest. Supraventricular tachyarrhythmias originate above the ventricles, most commonly within the atria or AV node. Because ventricular conduction usually occurs through the normal His-Purkinje system, the QRS complex remains narrow. These arrhythmias develop because of enhanced automaticity, triggered activity, or re-entry mechanisms. They are important because they may cause palpitations, hemodynamic compromise, thromboembolic risk, or tachycardia-induced cardiomyopathy. Sinus tachycardia is a physiologic increase in heart rate originating from the SA node. It occurs because the body is responding to stressors such as fever, pain, hypovolemia, anxiety, or hyperthyroidism. Treatment should focus on correcting the underlying cause rather than suppressing the sinus node unnecessarily. Atrial fibrillation is the most common sustained arrhythmia and results from multiple chaotic atrial impulses firing simultaneously. Because the atria do not contract effectively, blood flow becomes stagnant, particularly in the left atrial appendage. Atrial fibrillation increases stroke risk and may worsen heart failure or reduce exercise tolerance. Management focuses on rate control, rhythm control in selected patients, and anticoagulation assessment. Atrial flutter results from a large organized re-entry circuit, most commonly within the right atrium. Rapid atrial depolarization produces the characteristic sawtooth flutter waves on ECG. Atrial flutter carries a thromboembolic risk similar to atrial fibrillation and may produce rapid ventricular rates that impair cardiac output. AV nodal reentrant tachycardia occurs because dual AV nodal pathways create a re-entry circuit within the AV node. Rapid cycling through these pathways generates a sudden-onset regular narrow complex tachycardia. Therapies that transiently block AV nodal conduction, such as vagal maneuvers or adenosine, can terminate the rhythm effectively. AV reentrant tachycardia occurs when an accessory pathway connects the atria and ventricles outside the AV node. In Wolff-Parkinson-White syndrome, impulses bypass normal AV nodal delay and pre-excite ventricular tissue. Atrial fibrillation in WPW can conduct extremely rapidly to the ventricles, potentially degenerating into ventricular fibrillation. Let's summarize the management of stable narrow complex supraventricular tachycardia. The initial therapy includes vagal maneuvers and adenosine because these arrhythmias usually depend on AV nodal conduction. If unsuccessful, beta blockers or calcium channel blockers may slow AV nodal conduction further. Understanding the underlying mechanism allows clinicians to choose therapies that interrupt the re-entry circuit safely and effectively. Ventricular arrhythmias originate from the ventricular myocardium or Purkinje system and usually produce wide QRS complexes. These rhythms occur because ventricular activation bypasses the normal His-Purkinje conduction system. Ventricular arrhythmias are critically important because they are major causes of sudden cardiac death. Ventricular arrhythmias classify into PVCs, ventricular tachycardia, torsades de pointes, and ventricular fibrillation. These rhythms differ in severity because some preserve partial cardiac output while others eliminate effective ventricular contraction completely. Clinically, differentiating among these arrhythmias guides urgency and treatment selection. Premature ventricular complexes are early ventricular depolarizations arising from ectopic ventricular foci. They occur because ventricular tissue becomes electrically irritable due to ischemia, electrolyte abnormalities, stimulants, or structural heart disease. Isolated PVCs are often benign, but frequent PVCs may indicate underlying cardiac pathology or increase arrhythmia risk. Ventricular tachycardia consists of 3 or more consecutive ventricular beats at rates above 100 beats per minute. Monomorphic VT usually develops from stable scar-related reentry circuits, while polymorphic VT reflects unstable or multiple ventricular activation pathways. VT matters because sustained episodes may rapidly deteriorate into ventricular fibrillation and cardiac arrest. Torsades de pointes is a polymorphic ventricular tachycardia associated with prolonged QT interval. Delayed ventricular repolarization allows early after depolarizations to trigger unstable ventricular rhythms. Clinically, many medications prolong the QT interval, making torsades one of the most important drug-induced arrhythmias. Ventricular fibrillation is chaotic ventricular electrical activity without coordinated contraction. Electrical impulses circulate randomly throughout the ventricles, preventing effective cardiac output. VF causes immediate cardiac arrest and requires immediate defibrillation. Wide complex tachycardia should be considered ventricular tachycardia until proven otherwise. VT is especially likely in patients with prior myocardial infarction or structural heart disease because scar tissue promotes ventricular reentry circuits. Misdiagnosing VT as supraventricular tachycardia may result in inappropriate therapy and cardiovascular collapse. Management of ventricular tachycardia depends on hemodynamic stability. Unstable VT requires immediate synchronized cardioversion because cardiac output is compromised. Stable VT may be treated pharmacologically using antiarrhythmics such as amiodarone or procainamide. Recognizing instability quickly is critical for survival. Torsades de pointes is treated primarily with intravenous magnesium sulfate. Magnesium stabilizes ventricular electrical activity and suppresses early after depolarizations. Additional management includes correcting electrolytes and stopping QT prolonging medications. Early recognition prevents progression to ventricular fibrillation. Ventricular fibrillation requires immediate defibrillation, CPR, epinephrine, and advanced cardiac life support interventions. These therapies are necessary because VF produces no effective cardiac output. Rapid defibrillation is the most important determinant of survival. Antiarrhythmic drugs suppress abnormal rhythms, slow conduction, prolong refractoriness, and restore organized electrical activity. These effects occur because arrhythmias depend on abnormal ion channel activity and altered conduction pathways. Antiarrhythmics may improve symptoms and reduce arrhythmia burden, but they also carry significant proarrhythmic risk. This classification organizes antiarrhythmic drugs according to the ion channels or receptors they target. Sodium channel blockers affect conduction velocity, beta blockers reduce sympathetic stimulation, potassium channel blockers prolong repolarization, and calcium channel blockers suppress AV nodal conduction. Understanding this framework helps predict ECG changes, therapeutic uses, and toxicities. Class 1 antiarrhythmics block sodium channels in fast response cells, slowing ventricular conduction and widening the QRS complex. These effects occur because sodium influx is responsible for rapid phase 0 depolarization. These agents may suppress ventricular arrhythmias, but excessive sodium blockade can provoke dangerous proarrhythmia. Beta blockers reduce sympathetic stimulation and decrease calcium influx into nodal tissue by lowering cyclic AMP levels. This slows heart rate, reduces AV nodal conduction, and suppresses automaticity. Beta blockers are essential for atrial fibrillation rate control and prevention of arrhythmias after myocardial infarction. Class 3 agents prolong ventricular repolarization by blocking potassium channels, increasing refractory periods and interrupting reentry circuits. These drugs are highly effective for atrial and ventricular arrhythmias, but QT prolongation may increase the risk of torsades de pointes. Non-dihydropyridine calcium channel blockers suppress AV nodal conduction by blocking L-type calcium channels. This slows ventricular response in supraventricular arrhythmias. These drugs are commonly used for rate control in atrial fibrillation and management of AV nodal reentrant tachycardia. Adenosine transiently blocks AV nodal conduction and terminates AV-nRT. Magnesium stabilizes ventricular myocardium in torsades de pointes. Digoxin increases vagal tone and slows AV nodal conduction. These drugs remain important despite not fitting neatly into the von Willems classification.